There are things I know now, after years in the emergency department, that I wish someone had told me in residency, not about algorithms or procedures, about how this job actually works. Today, I'm sharing 4 lessons, 4 things that can fundamentally change how you practice if you let them. Hi, I'm Chet Shermer, and I've been practicing emergency medicine for 25 years. I remember residency like it was yesterday, and I really wish someone had given me this perspective sooner. Let's get into it. Residency is designed to build confidence, and you need that. Decisiveness saves lives in the emergency department, but there's a trap. Somewhere around years 3 to 7 of practice, confidence can start to outpace competence. You begin to pattern match faster than the data supports, and you stop pausing on the cases that really deserve a second look. The physicians who make the most dangerous errors aren't always the inexperienced ones. Sometimes they're the ones who stop being curious, who stopped asking, "What am I missing?" The antidote isn't self doubt, it's productive doubt, the ability to act decisively while still holding open the question, "Am I right?" That tension, confidence plus humility, is what separates good emergency physicians from great ones. Lesson 1: Uncertainty is the job. Patients don't arrive in your emergency department with diagnoses stamped on their foreheads. They arrive with complaints, vital signs, and incomplete stories. Your job isn't to eliminate uncertainty. Your job is to manage it, to make the best possible decision with incomplete information under time pressure, and accept that uncertainty is a permanent part of this specialty. Here's something residents often undervalue. Your clinical gestalt is data. That unease you feel about the patient who looks fine but something seems off matters. Work it up. Comfort with ambiguity is a clinical skill, and you have to develop it deliberately. Lesson 2: The chart is not the patient. Emergency medicine moves fast. It's tempting to read a chart, form a mental model, and then see the patient through that lens. That's a cognitive trap. The chart is a hypothesis about the patient. It is not ground truth. Prior diagnoses were made by someone else, under different circumstances and with different information. Labs and imaging reflect a moment in time. The patient in your bay right now may be a very different physiologic picture. Always ask yourself, does what I see in front of me match what's in this chart? When the answer is no, trust the patient. Update your mental model. The chart can be wrong. The patient can't. Lesson 3: Disposition is a diagnosis. Every time you discharge a patient, you're making a clinical decision that carries real weight. In emergency medicine, we focus intensely on the workup, the labs, the imaging, the consults. We spend less time on the decision to send someone home. That needs to change. Disposition deserves the same diagnostic rigor as everything else. Before you discharge, ask yourself 3 questions. What's the worst case diagnosis I haven't ruled out yet? Does this patient have the capacity and support system to return if they get worse? And is my documentation defensible if this patient comes back in worse condition? Disposition is a diagnosis. Treat it that way. Lesson 4: Every attending was once you. Residency is uncomfortable. You'll make mistakes. You'll have moments when you feel completely out of your depth and wonder if you belong in this specialty. I want you to hear this clearly. Discomfort is not a sign that you don't belong. Discomfort is a sign that you're learning. Every attending you admire, every physician who moves through a trauma bay with calm precision went through exactly what you're going through. They made the same mistakes. They had the same doubts. Competence is not issued at graduation. It's earned through repeated encounters. Seek mentors. Debrief after bad outcomes. The gap between where you are and where you want to be does close, but only through deliberate reflective practice. Let me pull this together. 4 lessons, 1 standard. Number 1, uncertainty is the job. Don't fight it. Manage it skillfully. Number 2, the chart is a hypothesis. Always verify it against the patient in front of you. Number 3, disposition is a diagnosis. Apply the same clinical rigor to sending someone home that you apply to the workup. Number 4, discomfort signals learning. The attending you want to become is built through exactly the moments that feel hardest right now. Sustained reflective practice, thinking critically about your own decisions, seeking feedback, and debriefing tough cases is what separates a good physician from an exceptional one. Pick one of these and apply it this week. That's the Global MedOps Command Clinical Brief. If this landed for you, share it with a resident who needs to hear it. Subscribe for a new brief every week. The full Emergency Medicine Clinical Brief playlist is linked in the description. And if you're looking to build the operational side of your practice, documentation, billing, AI tools, and contracts, visit globalmedopscommand.com. See you in the next one.